of my situation. I was talking about vaccines in transplantation. So your doctor tells you to get a vaccine, and you look at him and say,
"What do you mean?"
Your immune system is weak from the meds you take and needs some help to catch a break against diseases that could wipe you out. So listen to this thing I'm going to talk about. There's a lot of misconceptions about vaccines like pharma, autism. You know what I mean? But vaccines are safe, effective, and work to protect you against all the microbes that lurk. You can't catch the flu from the vaccine, but flu can lead to pneumonia, and you'll need a breathing machine. So listen to your friends from the AST. It's easier than counting.
1, 2, 3.
Say, I'm a transplant patient, and I need you to know that vaccines are lifesavers, and there you go. Come on. I need to hear you sing it. This is what I'm going to sing. You need a vaccine, but you say it's just a shot, but it's more than just a shot. Oh baby, you need a vaccine. It'll keep you from getting sick, and it's more than just a sick. Oh baby, you need a vaccine, but you say it's just a shot, but it's more than just a shot. Drop the mic.
Good afternoon, and welcome to the first webinar of 2019 in the ACCP Immunology and Transplantation PRN Webinar Series. My name is Angela Maldonado, and it is my pleasure to moderate today. Today's webinar is titled Vaccination and Solid Organ Transplantation, and we are honored to have Mary Haney and April Potabaum present for us today. Dr. Mary Haney is our first speaker, and she's a professor of pharmacy at the University of Wisconsin-Madison. Dr. Haney received her Bachelor of Science and Doctor of Pharmacy degrees from the University of Minnesota and her MPH from the University of Wisconsin. She did a postdoctoral fellowship in clinical pharmacology and vaccine research at the Mayo Clinic and Foundation in Rochester, Minnesota. Her clinical practice is with the lung transplant program at the University of Wisconsin Hospitals and Clinics. Her research interests lie in host response to vaccination, particularly vaccine responses by immunosuppressed populations, and she has published several manuscripts describing hepatitis B, tetanus, diphtheria, and influenza vaccine responses in lung transplant patients. Her teaching responsibilities include immunology pharmacotherapy for pharmacy students. She developed and teaches an immunization delivery course and has taught over 2,500 pharmacists and pharmacy students to provide this key preventative health service to their patients. Our second speaker is Dr. April Potabaum, who is a clinical pharmacy specialist at Barnes-Jewish Hospital. April received her PharmD degree from South Dakota State University and then continued her training at Barnes-Jewish Hospital, where she completed a pharmacotherapy specialty residency with a PGY2 emphasis in solid organ transplant. She currently works in the outpatient clinics with the kidney transplant and heart transplant populations. In a moment, I will turn it over to the speakers to begin the presentation, but first, here are a few housekeeping items. If at any point during the presentation you have a question for the speaker, please submit your question by using the chat functionality on the left-hand side of your screen and send the question to the presenter group. We will take questions at the completion of the presentation. There will be an evaluation for this webinar available at its conclusion, and we encourage you to complete this to let us know how we did and how we can improve our webinars going forward. The slides from today's presentation will be posted on the ACCP website in the section titled Webinar Slides after the presentation. If you experience any technical difficulties during this webinar that are not fixed by logging out and refreshing your internet connection, please make the presenters aware through the chat functionality. There's also a live chat on the upper right-hand corner of your screen where you can get live technical support from any meeting. Now, without further ado, I will turn it over to Dr. Mary Haney.
Okay. Hi, this is Mary Haney, and it's my pleasure to join the group today. I'm going to talk about immunologic, some timing, and some risk issues, and then turn it over to April. Okay. First, I think one of the things that has long plagued immunization in the field of solid organ transplantation is the worry that we might do other things, unintended things, to the immune system, such as what about what will happen to the immune system when we do it. So Molly and colleagues did a meta-analysis that was published just late last year. It included 90 studies that had over 15,000 vaccinated patients with almost 43,000 controls. And they looked at de novo donor-specific antibodies, the incidence of acute rejection, and graft loss, all in this meta-analysis. And I'm going to go over some of those, their results. There we go. First, let's start with de novo DSA. The Molly meta-analysis did look at this, and they found 23 cases among 1,244 patients, and they found those in 15 studies. However, the quality of this work, of the research, was deemed pretty low, primarily due to the lack of controls in the studies. But we all know that the Catarina's study had a relative risk of about 2.2 for HLA antibody or donor-specific antibodies. But please know that that was done with pandemic vaccine, and those individuals in that study all received 3 doses of influenza vaccine that season, because they received the seasonal vaccine, and then they received 2 doses of Adjuvanted pandemic vaccine, a vaccine that was not even licensed in the United States at this time. Or at that time. And then, but they further went on and found an induction of just HLA antibodies did not happen. It was 26 cases out of 1,000, almost 1,100 patients in 12 studies. The meta-analysis also went on to take a look at acute rejection. And in this case, they found 83 studies reporting 107 cases of acute rejection in about 5,000 patients. And their time frame for acute rejection was 0.7 to 6 months. And 46 studies reported absolutely no rejection. And then I put together this table from their results showing that the risk might be different for different organs. However, none of these reaches statistical significance anyway. And then finally, to go on to talk a little bit more about acute rejection, the estimated risk, the relative risk is about 1.1. And again, but again, it's not statistically significant, and you see the confidence interval there. The quality of evidence is better compared to the DSA evidence because 8 of the studies that were included in the meta-analysis for acute rejection were actually controlled studies. And then Hearst published a large registry analysis with almost 10,000 vaccinated patients among 52,000 kidney transplant patients and found an odds ratio of 1. And the limitation, of course, with the registry study is you really can't put together a temporal relationship between vaccine administration and the episode of rejection. So that's difficult to do, of course, in a registry study. And then finally, with acute rejection, multivariate analysis showed no effect of adjuvant. Granted, though, I think I'll talk about questions that we still have around this. But something to keep in mind is new adjuvants keep getting licensed. So, or no, that's not. I did not say that correctly. Vaccines get licensed with an adjuvant. So new adjuvanted vaccines may be licensed in the future. And then also there was no effect based on type of vaccine that could be detected for precipitation of acute rejection risk. And then the last portion of this meta-analysis examined graft loss. There were 7 studies, and among the 507 patients, there were 8 graft losses at 6 to 12 months post-vaccine administration. This table, pulled directly from the meta-analysis, shows the different vaccines as well as the transplant types and the follow-up time and the graft loss. And the risk of graft loss. Some limitations from this study: almost all of the studies that were included in the Mully meta-analysis were really primarily designed to examine vaccine response. They were not looking for immunologic sequelae. So the investigators, the meta-analysis investigators, examined these vaccine studies to look for immunologic sequelae. Also, as you may know, the varied immunosuppression regimens may confer different risks, and then certainly varied outcomes by transplant type or even vaccine is possible. And then these were the limitations listed in the study, but I'd like to add one myself. What is the appropriate timeline from vaccine to outcome of interest that you should examine? Like, for example, I would hypothesize that the timeline from vaccine administration to DSA to acute rejection to graft loss would occur in that order. But I don't know the appropriate time frame that you would consider a person at risk for say development of donor-specific antibody from a distance of time from vaccine. So I hope you understand what I'm after here is I think that even needs to be established yet. So we don't know, there's a lot we don't know. The bottom line is there is no strong signal regarding DSA formation, HLA antibody formation, or rejection following vaccination. So therefore, I highly recommend that you use clinical guidelines to vaccinate solid organ transplant patients. I now want to talk a little bit about immunosuppressants and their effect or potential effect on vaccine response. And I'm not really sure why I started out with rituximab, but I did. And but anyway, rituximab is one of our most potent immunosuppressants, and probably, and both data gleaned mostly from solid organ oncology literature, says that you probably shouldn't vaccinate a patient, or you can't expect much of a vaccine response if a dose of rituximab has been administered in the last 6 months. If you can vaccinate at least 4 weeks before a dose of rituximab, the best information, of course, is with influenza or pneumococcal vaccines. And typically with rituximab, live vaccines are considered contraindicated. With the calcineurin inhibitors, I can find no information that gives me an idea of that one is a real front runner over the other when it comes to vaccine response. You'll find studies that favor one over the other, but I don't think that there is a real front runner here when it comes to vaccine response. For anti-proliferative agents, there's a pretty good known effect on mycophenolic acid. It does appear that the effect on vaccine response is dose-dependent. Azathioprine has varying responses, but probably a minor effect on vaccines. The best information on azathioprine is actually from the autoimmune literature, where you'll have a patient on just azathioprine as sole therapy. Corticosteroids, probably dose-dependent effect, as we use them in log-fold differences of doses. And then some induction agents. There was a study done that compared basiliximab to ATG using the seasonal influenza vaccine, and the study found no difference between the groups. The one thing that I found about this study is though it may have been underpowered, because their sample size calculation was based on a seroconversion rate of 80%, and they thought they could detect a difference to 50%. 80% seroconversion rate for any influenza vaccine study is a really high rate. So maybe their sample size calculation might not have been quite where it should have been. So I worry about that study being underpowered. Then another issue is although kind of being put to bed, and this might be an old issue, is when to vaccinate. And I'm talking about when to vaccinate in relation to transplant time. We always think that immunization pre-transplant makes a lot of sense. And so immunization pre-transplant is based on data like this, shows that this is influenza vaccine, shows pre-transplant immune responses are typically higher compared to post-transplant. For the most part, pre-transplant patients are not immunosuppressed, or at least less immunosuppressed. This study also included individuals who were less than 6 months post-transplant. You'll see the immune responses to influenza vaccine are low, but they still are detectable. And then this was one of the things I found very interesting with this study is what about the people who are more than 10 years post-transplant? And these patients, I guess another detail that you need for this study is these are lung transplant patients where median survival is just over 5 years. So 10 years from a lung transplant is, a long time. And it appears as though that the 10-year people have, or 10 or more year people have a very good response to vaccines. So they may be, is that one of the things that makes them survive longer? I'd like to think so, but I doubt that's true. And then finally, another way to look at influenza vaccine response is seroconversion rates. Mentioned earlier that pre-transplant patients had higher seroconversion rates compared primarily to those who were immediately post-transplant in the 0 to 6 month time frame. And again, the long-term survivors also had a really good response rate. And then finally, I'm going to finish up with what is the risk of vaccine-preventable diseases in transplant patients. Influenza is best studied in lung transplant patients, where the risk in one study was between 2 and 16%. Whereas adults, these are really old data, and these are from the late 70s, where the adults have about a 10 to 15 per 100 person year attack rate from influenza. Back in the days when we didn't use a lot of vaccine, and then consider that the lung transplant patients may be heavily immunized. Invasive pneumococcal disease in a recent study showed that the case rate for transplant patients is about 500 per 100,000, whereas in healthy adults it's about 10 per 100,000. And then the risk of zoster in transplant patients is likely about double the risk of zoster in healthy adults. And then just published last week is vaccine-preventable diseases in children report. About 16% of children were hospitalized for a vaccine-preventable disease in the 5 years after transplant. These children were followed from transplant time through 5 years. Most common was influenza, rotavirus, varicella, and then pneumococcus. The highest risk for a vaccine-preventable disease included lung, heart, intestine, or multivisceral transplant, or children who were younger than age 2 at the time of transplant. And then I put this comment in quotation marks because it was in the discussion of the paper and referenced. Less than half of all transplant recipients reported being up to date for age at the time of transplant. And so that is one of those things when you see what the pre-transplant patient is let's do everything we can to get them immunized before the transplant. Finally, I think there's a lot we don't know about vaccinating transplant patients. I tried to highlight some of those issues as we go along, like the effect of combination immunosuppressant. Most of the time I'm highlighting just one immunosuppressant. What is the time frame that we should be looking for our endpoints? But right now it appears there is no strong safety signals to consider, and the risk of vaccine-preventable diseases in this population is quite high. Therefore, vaccinate.
Okay, so as Dr. Haney just mentioned, it's important to vaccinate our solid organ transplant patients due to the high risk of these vaccine-preventable diseases in this particular patient population. And today, I wanted to talk about some of the vaccines that I received the most questions about in clinical practice. But before we dive into those specific vaccines, I wanted to talk about some general information. Sorry, there's a bit of a delay here. So first, then we think about general principles from the IDSA guidelines that talk about vaccination recommendations in immunocompromised patients. They do mention specifically that standard age-appropriate inactivated vaccine series should be administered based on the CDC annual schedule. And so I think as we dive into these particular vaccines of interest today, it's important to keep in mind that patients should really be up to date on all of their vaccinations that are indicated based on their age. Generally speaking, we could consider administration beginning anywhere from 2 to 6 months after transplant once patients have attained kind of their maintenance immunosuppressive levels. Generally, we're going to withhold vaccination during periods of intensified immunosuppression, which would include those first few months post-transplant because of the high likelihood of that inadequate response. Now, as I mentioned, I wanted to focus on some of the vaccinations that I get the most questions about in clinical practice. And we're going to start today by talking about the influenza vaccine. So as we're all aware, ACIP has recommended routine annual vaccination for all patients aged 6 months or older who don't have contraindications for the vaccine. Both ACIP and IDSA actually provide guidance for influenza vaccination in our immunocompromised patient population. And what they've really come out and said is that we should pick an activated influenza vaccine or the recombinant influenza vaccine for immunocompromised patients. And they specifically indicate that we should avoid the live attenuated influenza vaccine due to the risk of disease attributable to vaccination with a live attenuated vaccine in immunocompromised patients. Now, I think that this recommendation to avoid the live attenuated influenza vaccine is particularly relevant for the current 2018 and 2019 flu season because following 2 years in which ACIP recommended against the use of the live attenuated influenza vaccine, it's now been reintroduced as an appropriate option for some patients based on their age and medical comorbidities. And so it's just another reminder for us as pharmacists to make certain that our providers and our patients are educated about the fact that we really should be avoiding live attenuated flu vaccines in immunocompromised patients. Now, with that being said, I think that generally speaking, most providers and most patients are aware that we need to avoid live vaccines in the immunocompromised patient population. But the next question that comes then is, what about household contacts? So with regard to household contacts, it's generally safe for household contacts of our solid organ transplant recipients to receive the live attenuated influenza vaccine if they would meet eligibility criteria based on their age and medical history. The IDSA actually specifically provides a few exceptions for this, where they specifically point out that household contacts of particular immunosuppressed patients, so those household contacts of hematopoietic stem cell transplant recipients who are within the first couple months after transplant or have GVHD, or household contacts of patients with severe combined immune deficiency, that they should not receive that live attenuated influenza vaccine. However, we see here that solid organ transplant was not specifically carved out, and so generally speaking, the household contacts of our patients are able to safely receive the live attenuated flu vaccine without any notable safety concerns at this point. Transitioning to dive a little bit more into influenza infection in solid organ transplant, we know that influenza in our transplant recipients is associated with both short-term and long-term complications, including secondary bacterial pneumonias, allograft rejection, and mortality. And so, as we've just discussed, annual influenza vaccination is recommended in order to prevent these influenza-associated complications. Unfortunately, though, what we've seen is the immunogenic response to influenza vaccine tends to be lower and more heterogeneous in transplant recipients as compared to immunocompetent hosts. And so the available literature is quite diverse in that seroprotection rates range anywhere from 15 to 90%. And certainly, a lot of this is due to the fact that the immunogenic response can be influenced by a lot of different factors, including type of immunosuppression, time from transplant, type of allograft, all of these things. But generally speaking, we can say that oftentimes our patients are going to have suboptimal immunogenic responses. For that very reason, we've started to look at different strategies to improve vaccine immunogenicity in our solid organ transplant recipients. On this slide, I've really tried to highlight some of the novel strategies that have been evaluated in order to increase immunogenicity. Starting at the top of the screen, we'll see that intradermal influenza vaccination has been studied, and really the thought here is that the intradermal route of administration has been proposed to increase immunogenicity because the dermis contains a large number of dendritic cells that can act as potent antigen-presenting cells. Unfortunately, though, we saw that the intradermal vaccination route didn't really show clear benefits over the standard intramuscular injection in terms of immunogenicity, and we saw that in some of the studies there was an increased frequency of the injection site reactions. And so generally speaking, the intradermal route is probably not the best option to enhance immunogenicity. We've also looked at the adjuvanted influenza vaccine in solid organ transplant. And in this particular study here, the adjuvant was used to attract inflammatory cells to the site of infection. And again, we saw kind of similar results where that there wasn't a clear benefit in terms of immunogenicity, but there was the potential for increased injection site reactions. As we move further down, though, we see that both the high-dose flu vaccine and the use of booster doses have been shown to enhance immunogenicity in some studies, and so I wanted to focus a little bit more on those potential strategies today. We'll start by discussing the evidence to support the use of the high-dose flu vaccine. And the first study that I'll be discussing compared a standard dose flu vaccine to a high-dose flu vaccine in pediatric solid organ transplant patients. Now, this study was actually designed to look primarily at safety outcomes, and so it wasn't powered to compare the immunogenicity of the high-dose and the standard dose vaccines. But what we did see is that the high-dose group had a significantly improved response for the H3N2 strain contained in the vaccine, here suggesting that that higher dose may be more immunogenic and provide better short-term protection in this particular patient population. A similar study was also done in adult transplant patients, and this study was actually published in CID last year, and it again compares the standard dose flu vaccine to the high-dose flu vaccine. The study found that the high-dose influenza vaccine had better immunogenicity as determined by their primary endpoint of seroconversion. And this increased rate of seroconversion was consistent across all three of the influenza subtypes that were contained within the vaccine. The other thing on the right-hand side of the screen, we see that the proportion of patients who responded to 1, 2, or 3 vaccine strains was higher in patients who received the high-dose vaccine. And so collectively, we now have data in both pediatric patients and adult patients showing that this high dose may allow enhanced immunogenicity and allow us to better protect our patients. Another strategy that has been used to enhance immunogenicity is use of booster doses. So a booster dose given weeks after administration of the standard dose may elicit a more long-lasting antibody response, resulting in better protection throughout the influenza season. The transcribed study shown here included solid organ transplant patients who were at least 16 years of age, and they were randomized to receive either routine vaccination with a single dose of the standard dose trivalent influenza vaccine, or they received that standard dose with a booster dose administered 5 weeks later. When looking at the study results here, we see higher seroprotection rates, again, for all 3 influenza strains for patients who received the booster dose of the vaccine, indicating again that repeating a booster dose of the flu vaccine within the same flu season may present an opportunity to better protect our patients from the flu. So when we look at collectively all of this information about influenza and the vaccines, we know that our solid organ transplant patients have an increased risk for morbidity and mortality from influenza infection. Currently, guidance from ACIP and IDSA recommends annual influenza vaccination in solid organ transplant recipients. And they do specifically say that we should use the inactivated flu vaccine or the recombinant flu vaccine because we should be avoiding the live attenuated influenza vaccine in this patient population. With that being said, though, we've just seen that use of the high-dose vaccine or booster doses has been shown to enhance immunogenicity of the flu vaccine in solid organ transplant recipients. And so I think certainly we have a lot of remaining questions with regard to optimal dosing strategies of these vaccines and what is their overall effect on preventing clinical disease. But all of this information presents that we do have some potential options in order to enhance immunogenicity and perhaps better protect our patients. Transitioning then, we'll now move on and talk a little bit about pneumococcal disease and pneumococcal vaccination in solid organ transplant. So Streptococcus pneumoniae can cause serious illness in our patients, including bacteremia, meningitis, pneumonia. And what we've seen is that the incidence of invasive pneumococcal disease as well as the mortality rates are higher in solid organ transplant recipients as compared to the general population. For that reason, pneumococcal vaccination of our solid organ transplant recipients is recommended in order to prevent this invasive pneumococcal disease. In the United States, we currently have both a pneumococcal polysaccharide vaccine and a pneumococcal conjugate vaccine available for use. The polysaccharide vaccine contains purified pneumococcal polysaccharides, and the current vaccine is 23 serotypes, and it provides the broadest coverage of the pneumococcal vaccines available. Nevertheless, the polysaccharide vaccine induces more of a restricted IgG response, and so the immune response to those capsular polysaccharides is T-cell independent and has a limited duration. And so because of these limitations, a conjugate pneumococcal vaccine was developed in order to enhance the immunogenicity of this polysaccharide vaccine. In the United States, the one we have available is the PCV13, and so this pneumococcal conjugate vaccine includes 13 different serotypes. And with the conjugate vaccine, it really contains these pneumococcal polysaccharides that are covalently bound to an immunogenic carrier protein. And what the addition of the carrier protein does is it allows a T-cell dependent response, and it allows the B-cell differentiation into memory cells. So generally speaking, there have really been several small studies that have evaluated the use of these pneumococcal vaccines in solid organ transplant patients. And generally speaking, what we see is that these studies reveal that solid organ transplant recipients can respond to the pneumococcal vaccines when we look at their rise in antibody titers, but the response is generally going to be less intense and of shorter duration than we see in healthy controls. And again, just like we saw with the influenza vaccines, we've sought out to try and figure out, are there ways to improve vaccine immunogenicity in our particular patient population? The prime boosting strategy is one strategy that was suggested to potentially be beneficial for solid organ transplant recipients. The prime boosting strategy really involves administration of the pneumococcal conjugate vaccine followed by that pneumococcal polysaccharide vaccine. And really, the rationale here is that the T-cell dependent response from the conjugate vaccine is more effective in producing memory B cells that could then be boosted if we give that polysaccharide antigen vaccine to produce a larger amount of antibody. So there was evidence in some immunocompetent patient studies and some studies in other immunocompromised patients actually that this prime boosting strategy had been shown to be beneficial. And consequently, it was studied in the solid organ transplant population. Shown here are the results from some selected studies evaluating this prime boosting strategy in solid organ transplant. And you'll notice that overall, these studies have not shown a substantial benefit with this prime boosting strategy. Now, although the literature to support the optimal pneumococcal vaccination schedule in solid organ transplant is limited and not really supportive of a particular regimen, both ACIP and IDSA guidelines recommend that solid organ transplant recipients should receive the pneumococcal conjugate vaccine followed by the pneumococcal polysaccharide vaccine, and the need for booster doses is going to be based on patient age and their pneumococcal vaccination history. Recommendations for this dosing strategy are primarily derived from the potential benefits of this schedule in other patient populations. On this slide and on the next slide, I've just included diagrams that show the pneumococcal vaccination schedule for adult patients for your reference. Please note that all solid organ transplant recipients, including pediatric patients, should receive pneumococcal vaccinations. I just didn't include these flow diagrams for pediatric patients since there's more variability based on patient age and vaccination history. So overall, when we think about pneumococcal disease and pneumococcal vaccination, quite honestly, the optimal pneumococcal vaccine schedule in solid organ transplant recipient remains largely unknown. Some studies have evaluated that prime boosting strategy, but it hasn't demonstrated enhanced immunogenicity in the solid organ transplant patient population. As of now, guidance from ACIP and IDSA does recommend vaccination with that pneumococcal conjugate vaccine followed by the polysaccharide vaccine, and the need for revaccination is going to be determined based on patient age and their pneumococcal vaccination history. Lastly then, I wanted to shift gears and talk about a newer vaccine we have here, and we're going to talk a little bit more about Herpes Zoster. So Herpes Zoster, commonly known as shingles, affects approximately 1 million people in the United States each year. And shingles occurs when latent varicella zoster virus is reactivated, and so it makes sense that the natural history of shingles is influenced by the overall immune status of the host. Notable risk factors for shingles include increasing age and immunocompromised states. And so, with increasing age, we see an age-related decline in the immune response. And with immunocompromised states, we see reduced T-cell mediated immunity. Herpes zoster is typically going to manifest as a vesicular, painful dermatomal rash, and unfortunately it can lead to a variety of complications. So we can see neurologic, ocular, and cutaneous complications. The most common complication, though, which we're all probably familiar with, is this post-herpetic neuralgia, which is defined as persistent pain for at least 90 days following resolution of the herpes zoster rash. And unfortunately, the pain and discomfort associated with post-herpetic neuralgia can be disabling and ultimately decrease the quality of life for our patients. So the best way to avoid shingles and its associated complications is through vaccination. In May of 2006, the FDA approved the live attenuated herpes zoster vaccine, which goes by the trade name of Zostavax, and it's shown here on the left-hand side of the screen. Although Zostavax offers some degree of protection against shingles for particular patient populations, unfortunately it is a live vaccine, and so it's contraindicated in the solid organ transplant population. So, if you're like me, you were particularly excited when the FDA approved a non-live recombinant herpes zoster vaccine in October of 2017, and this vaccine goes by the brand name of Shingrix. So on this slide, I've really just tried to highlight some of the notable differences between the two vaccines. We've already highlighted that Zostavax is a live attenuated vaccine, so it's contraindicated in solid organ transplant patients, whereas Shingrix is a non-live vaccine, so would be appropriate for use. Both of the vaccines are indicated per manufacturer's labeling in patients aged 50 years of age and older. That being said, there is differences in dosing. So people are used to, the shingles vaccine being just a one dose. So Zostavax is given as a single dose administered subcutaneously. And now with Shingrix, we have a 2-dose series, and it's administered intramuscularly. Lastly, I think this is really important on the bottom of the screen, is looking at estimates of vaccine efficacy against herpes zoster. And we see that these estimates of efficacy against zoster were higher with the recombinant zoster vaccine as compared to Zostavax in all age categories, but the difference in efficacy was most pronounced among our older recipients. So I just mentioned that this recombinant zoster vaccine, or Shingrix, was FDA approved just over a year ago, and ACIP subsequently released recommendations for its use in January of 2018. So as of now, I've shown on the slide the ACIP recommendations for use. So they currently recommend the use of Shingrix in immunocompetent patients who are 50 years of age or older. They also specifically say that our immunocompetent adults that were previously vaccinated with Zostavax should still receive Shingrix. It's really been shown that this recombinant zoster vaccine elicits a similar immunogenicity and safety profile regardless of whether or not patients have previously received Zostavax. So the committee does believe that these patients will still likely benefit from the recombinant zoster vaccine. And then lastly, it's noted here that the recombinant zoster vaccine is the preferred herpes zoster vaccine, and this is primarily driven by those differences in vaccine efficacy that we just highlighted on the previous slide. So I think one of the big things to point out here is that you'll note that these recommendations for use focus on immunocompetent patients. And ACIP does not make any recommendations regarding the use of this recombinant zoster vaccine in immunocompromised patients, primarily because there's limited data demonstrating safety and efficacy of the vaccine in this patient population. Now, with that being said, there is some data to support the use of Shingrix in our solid organ transplant patients. This study here included adult renal transplant recipients who were on their chronic maintenance immunosuppressive therapy, and patients were randomized to receive either 2 doses of Shingrix or 2 doses of placebo. The study evaluated both efficacy and safety of the vaccine, and the preliminary results are shown here. So, as evidenced by the vaccine response rate, the preliminary results really show that the vaccine is highly immunogenic in the solid organ transplant population. Furthermore, on the bottom of the screen where we're looking at adverse effects, we see that Shingrix was associated with an increased incidence of local adverse effects, but it wasn't associated with an increased incidence of the systemic adverse effects. So I think that these results really do support the use of Shingrix in our solid organ transplant population as a potential means to prevent the development of shingles and its associated complications. So not surprisingly then, when we have the introduction of a new vaccine, prescribers have a lot of questions about its use in clinical practice. And so I want to touch on a few of the frequently asked questions that I get in my practice. So the first question is really, should I use this vaccine if a patient is known to be VZV seronegative? Before we discuss this question, I just wanted to put a disclaimer that screening for a history of varicella, either verbally or with lab serology before vaccination, is certainly not necessary. But if a patient is known to be VZV seronegative, then the ACIP guidelines for varicella vaccination should be followed. At the present time, the recombinant zoster vaccine has not been evaluated in patients who are VZV seronegative, and the vaccine is not indicated for the prevention of chickenpox. I think in the general population, this isn't a question that's going to come up a lot because we're not routinely checking VZV serostatus, but it has come up in our kidney transplant population here at Barnes-Jewish Hospital because we're routinely assessing the VZV serostatus during the pre-transplant workup. And so we do continue to use the varicella virus vaccine, or Varavax, if patients are found to be VZV seronegative. I've also received quite a few questions about use of the recombinant zoster vaccine in patients with active shingles or those with a history of shingles. And certainly we know that this vaccine is not a treatment for shingles, and so it should not be administered during an acute episode. It should, however, be used in patients with a history of shingles in order to prevent future occurrences of the disease. At the present time, there are not any specific recommendations about how long you need to wait after having shingles before you can receive the recombinant Zoster vaccine, but at a minimum, we need to make certain that the rash has gone away and they've recovered from that acute episode. There are studies of safety and immunogenicity in this population that are ongoing, and so hopefully in the future we'll have some more answers about optimal timing after an episode of shingles. Another question that's come up quite often is, is there a need to restart the vaccine series if more than 6 months have elapsed since the first dose? And to be honest, I think this question has been more common up front with the shortages of Shingrix in the community. And so it is not recommended to restart the vaccination series if there's been more than 6 months between that first dose. I would just recommend that we administer the second dose as soon as possible. Another question that comes up with regard to timing is how long do we have to wait after a patient received Zostavax in order to give the recombinant Zoster vaccine or Shingrix? So what we know is that the clinical trials have examined the safety and immunogenicity of this recombinant Zoster vaccine if and when it was given at least 5 years after Zostavax. Intervals shorter than 5 years haven't been studied extensively, but there's currently not any evidence to suggest that intervals less than 5 years would be less safe or less effective. And so I think intervals less than 5 years can certainly be considered, especially in older patients, since we've seen there are notable differences in vaccine efficacy in that patient population. And per ACIP recommendations, the recombinant Zoster vaccine just should not be given within 2 months after a patient has received Zostavax. So to kind of tie everything together once again, we know that our solid organ transplant recipients have an increased risk for herpes zoster and its associated complications. Current guidance from ACIP and IDSA does not make any recommendations regarding the use of this recombinant Zoster vaccine in our solid organ transplant recipients, but we do have preliminary evidence to suggest that the recombinant Zoster vaccine is highly immunogenic in our solid organ transplant recipients, and no safety concerns have been noted in this patient population. So when we look back at what we've talked about, standard age-appropriate and activated vaccine series should be administered in our solid organ transplant patients, just like they would for the general population. We see that the recommendations are for annual influenza vaccination with specifically the inactivated flu vaccine or recombinant flu vaccine in our solid organ transplant recipients. There's really no preference given to a particular product or a particular dosing scheme outside of that, but we have seen that novel dosing strategies such as use of the high-dose vaccine and use of booster doses have been shown to improve immunogenicity and could be considered in our patients. Pneumococcal vaccination is also recommended in solid organ transplant recipients. Again, it's recommended to give the Conjugate vaccine followed by the Polysaccharide vaccine. And then lastly, no current guidelines come out for either ACIP or IDSA to recommend the recombinant Zoster vaccine in solid organ transplant patients, but I definitely think it's something that should be considered in our patients based on the available evidence. Thank you for your time, and I think I will turn it over to Angela for questions.
All right. On behalf of the ACCP Immunology and Transplant PRN Planning Committee, we'd like to thank both of our excellent speakers. So we'll now open the webinar to questions. Again, you can enter your questions on the left side of your screen and send the questions to the presenter group. So our first question actually comes from one of our PRN members, and this is from Mary. Mary, has there been any data associating CD3 levels with vaccine responses?
Most of that work, am I okay?
Yes, we can hear you.
Okay. Sorry. I was reading the question and didn't check to see if my mic was on. For the most part, most of that work with CD subsets has been done in the HIV population, and mostly it depends on the CD4 count. Now, of course, is that a function of it being done in the HIV population? I don't know, but I haven't seen any studies in the solid organ transplant population, but that doesn't mean they don't exist.
Great. Our next question comes from Jennifer McDermott. Given existing guidelines, given existing guidelines do not recommend high-dose influenza vaccine or booster doses for solid organ transplant patients, but there is some clinical data showing improved immunogenicity, does your center give high-dose influenza vaccine to all transplant patients or follow age-based recommendations per ACIP guidelines? If you give high-dose in all, do you have reimbursement or payment issues, and how do you overcome these? And this question is for April.
Yeah, so I think this is a great question, and at our center, we actually do follow age-based recommendations per ACIP guidelines. So we have not gone down the route of using, just making a general statement about use of high-dose vaccines or booster dose vaccines. And it's primarily for the limitations that you just addressed in terms of vaccine coverage and affordability. The only time we're really using, booster doses specifically is, if we have to vaccinate somebody in that first month or two post-transplant when, we're in the middle of influenza season, then we'll give a booster dose later on. But generally speaking, we are following general ACIP recommendations and just trying to encourage high dose in patients who are over the age of 65 years.
Can I hop on that too?
Yeah.
Consider that most of the standard dose vaccine, influenza vaccine, is quadrivalent. So you add that second B coverage by using the quadrivalent vaccine in the younger populations as well. So in the lung transplant clinic where I see patients at UW hospital and clinics, we follow the age-based recommendations as well.
Great. Thanks, April and Mary. Our next question comes from Mie Kim from Boston. Does your center routinely give Shingrix to everybody greater or equal to 50 years old who are transplant patients? And if you do, when do you administer them in regards to antiviral prophylaxis with either Valcide or Valtrex? So do you wait until you complete these medicines, or do you time them from transplant, for example, 6 to 12 months afterwards for better immunogenicity? And any of our speakers can answer this.
This is April. So we are recommending Shingrix for routine vaccination in our post-transplant patients greater than 50 years of age. I think the question about administering them with regard to like Valcide and Valtrex prophylaxis is a little bit different than we used to see, where we were not able to really be on these antiviral medications when we give the live vaccine. There needs to be a period of holding. Those same recommendations are not do not need to be followed for Shingrix, given that it's a non-live vaccine. Our practice has actually been in the kidney transplant clinics is we are evaluating patients at 1 year post-transplant, and we've just kind of set the 1 year mark right now as kind of a way to help ensure patients are getting vaccinated, but we are routinely recommending Shingrix in our patients who are 50 years of age and older at this time.
Mary, do you have anything to add to this question?
The only thing I would add is pre-transplant is the time to do it.
Yes, definitely. All right. Our next question is Danielle Bischetto. I'm hoping I'm saying your last name right. Can you comment on your policy for use of Shingrix post-transplant? Our ID attendings are currently recommending against it until there is more safety data. And this is, I'm going to piggyback onto this question too, because we had our attendings come to our meeting and you know, say nobody's getting Shingrix until we have more data. So, April and Mary, what are your sort of advice to combat that sentiment?
Yeah, I mean, I guess it's a little bit different in my practice here at Barnes-Jewish Hospital in that our ID attendings were on board with vaccinating people with Shingrix post-transplant based on the evidence available. I think certainly from the studies in the general population, we see more local adverse effects with the use of Shingrix as compared to some other vaccines in practice, but I don't have any notable flags in terms of systemic adverse effects. I'd be interested to know what main safety concerns they have, to be honest with you, because it was not presented by ID physicians at our facility here.
I have nothing additional to add. We are, well, if I say I have nothing to add, I'm not going to add anything.
you know, I'm going to quote April's slides here and just say there's nothing to show that we shouldn't be doing it, right? Okay. So we have 3 more minutes for questions. We do want to end right on time, but we can go, if there's quite a few left, we can go a little bit over. Our presenters are willing to stay and answer all these lovely questions. So our next one comes from Fu Wing. Is there any comment or recommendation on the HPV vaccines, especially for our pediatric patients?
Yeah, so I think some of this goes back to, you know, kind of the general statement about standard age-appropriate and activated vaccine series really should be administered in our patients. We know that solid organ transplant patients in general have an increased risk of HPV-associated malignancies compared with the general population. And we know that trials of like this prophylactic HPV vaccines have been really effective in those who have been unexposed to those HPV types included in the vaccine. You know, the literature in solid organ transplant patients does show lower response rates compared to the general population, like we've seen with most other vaccines. But again, I don't have any notable safety concerns, and you know, I think the hesitation somewhat with the HPV vaccine are really hindered primarily by these like public perceptions about HPV status as a sexually transmitted infection and descent over the age group recommended for vaccination. But due to the potential efficacy and ability to prevent some of these HPV-associated malignancies and no major concerns about safety in this patient population, I really do think it should be recommended in our patients. And I think this is an opportunity for us to, again, provide education to help increase vaccination rates.
Thank you, April. That's such a great answer. And it is, you know, on the guidelines for age-appropriate vaccinations, regardless of transplant status. So I completely agree with you. I'm going to throw in a question to the both of you. As the CDC has just recently named anti-vaccination people as a top 10 global health threat, how do your centers approach the transplant candidate who is against the vaccination? Is it a contraindication to listing, or do you go ahead and list them for transplant knowing that they would not come into transplant with the vaccines that are recommended and would not get any of the recommended vaccines after transplantation?
We haven't run into that in really a long time. But for the most part, I don't know that it has been I don't know that it's ever risen to a contraindication to listing, because usually the patient will go, okay, I agree. You know, one of the things we want to think about and it's a philosophical issue here is that we recommend this for your health. I think we really encourage adherence to our recommendations. Why would you choose? Why would you get to pick and choose which of our recommendations you're willing to accept?
Yeah, and I feel the same way. April, what do you think?
Yeah, I was just going to say similarly, this isn't something, now that I reflect upon it, that I think we have a standard kind of response to. Certainly, I know the number of patients we're evaluating for kidney transplant each year, and so certainly this is something that has to come up. I don't interact with every patient, given the large volume, but I think it's an interesting discussion and something that's definitely worth, a discussion worth having moving forward.
All right, we have time for one more question, and our last question comes from Bharath Ravichandran from Maryland. What is your strongest evidence, in your opinion, regarding giving live vaccines post-transplant in regard to infectious risk? I know there is some limited data in pediatric patients on giving the MMR vaccine, but wanted to see if there was any other evidence opinion on this. And I'm assuming we're giving live vaccines to post-transplant adult patients who may have maybe missed their series as adults.
I am only aware of the limited data in pediatric patients with MMR vaccine.
Yeah, me as well. I'm not aware of any data with live vaccines in the adult patient population, which I think is why the recommendations from, ACIP and IDSA really discourage use of live vaccines due to the limited safety data available.
Mm-hmm. There's case reports of accidental administration of live vaccines to patients with HIV. That, of course, they're case reports because it didn't end well. So I think that this is something we should be very cautious about.
All right. Excellent presentations from both our speakers and equally stimulating questions from our audience. Thank you, everyone who logged in. And this concludes our webinar on vaccinations and solid organ transplantation. Thank you very much.